surgeries that will be performed. So before that, we'll just go through the surgical anatomy. So this is the parotid gland, and on the superior surface, you can see this neurovascular bundle. So this is the superficial temporal artery, along with the vein and the auriculotemporal nerve. So there are three structures in this bundle, and which go to the temporalis fascia. Remember, while doing the harvesting of the temporalis fascia, you can see some bleeders, and these are all branches of the superficial temporal artery. And this is the auriculotemporal nerve, and here you see is the temporal branch of the facial nerve, and these are the buccal branches, these are the cervical branches, and you will get a marginal mandibular at the angle of the mandible. And posteriorly, you will see this vein. This is a posterior auricular vein, which connects to the retromandibular vein and forms the external jugular vein. Here you see the Stinson stump. The landmark for this is the lower border of the tragus connecting to the filter or the lip. And this one takes an acute angle at the anterior border of the masseter and pierces the buccinator and enters the oral cavity at the level of the upper second molar. And once the gland is divided, you can see the structures lead to it. The most important and vital structure will be the facial nerve, of course. And the whole surgery, parotid surgery, revolves around the facial nerve. So you see the main trunk here, and it divides into two, the pes anserines, temporofacial and cervicofacial trunk. And before the main trunk divides, there is a nerve that goes to the posterior belly of the digastric. See, this is the nerve that goes to the posterior belly of the digastric. So it's called pes anserines, resembling the goose foot. So the superior branches are the temporofacial branches, which consists of the temporal nerve or the frontal nerve and the zygomatic branch. And the surface anatomy for the temporal branch will be the midpoint of the zygomatic arch. And inferior will be the cervicofacial trunk, which again divides into buccal, marginal mandibular, and the cervical. The buccal branches are firmly interconnected, so there is a leeway. Even if you accidentally cut one or two branches, the nerve recovers. But the marginal mandibular is the end-on nerve, so it doesn't recover. And deep to the facial nerve is the venous structures, the retromandibular vein, which is formed by the superficial temporal vein and the maxillary vein. And this facial nerve and the vein forms the facial-venous plane of Patting. So this is a good radiological sign to find out whether the tumor is in the superficial lobe or in the deep lobe. And inferiorly, it divides into anterior and posterior branches, and it connects to the posterior auricular nerve and forms the external jugular, and the anterior branch connects to the common facial vein and goes to the internal jugular. And further deep to it will be the artery. This is the external carotid artery that goes under the posterior belly of digastric. So you need to know that there are no vital structures superficial to it. So this again then divides into two terminal branches, the maxillary artery that goes into the pterygopalatine fossa, and you know the internal maxillary artery, which you can come across while ligating the for angiofibroma. And then the other terminal branch will be superficial temporal artery. That will be the superficial temporal artery. This then goes into the temporalis fascia and then supplies the musculature and the skin. That in short will be the surgical anatomy. So now, what are the types of parotid surgery? The most commonly done parotid surgery is the superficial parotidectomy, and the recent concept of another surgery is a partial superficial parotidectomy. In case the tumor is in the upper or in the lower pole, we don't have to do the complete superficial parotidectomy, but of course you need to delineate the facial branches, and then you limit yourself to either the inferior or the superior quadrant. The other types of surgeries are deep lobe parotidectomy, total parotidectomy, radical parotidectomy, which involves the removal of the facial nerve, and extended total parotidectomy. So what is the incision? The most common incision we use is the modified blade. So this is the modified blade incision, where the blades will be like this along the angle of the mandible. And even the most trending incision now, it's more fanciful, is the facelift incision or right-directed incision, where the incision is hidden in the hairline. And in lower pole tumors, very localized lower pole tumors, we can use even a V-shaped incision. So here you can see the incision is marked. So this is the modified blade incision. And the incision is taken behind and 2 finger widths away from the lower border of the mandible. That is to avoid the marginal mandibular nerve. And for dissection sake, we are extending it anteriorly so that it's easy to elevate the flap. But in surgeries, we don't usually do this part. It's also called the lazy S incision. And the principle of traction, counter traction is always applied for neck surgeries. And one of the most important steps is raising the S-mass flap. Why do you raise this flap? It's a thick flap that contains muscle fibers, superficial muscle fibers, the connective tissue and the skin on top. And why do you need to raise a thick flap? Is because that will add cosmosis to it. Once the gland is removed, there will be defect in the face, so that can prevent the facial depression. It reduces phrase syndrome. What is phrase syndrome? The cross innervation between the auriculotemporal nerve and the greater auricular nerve. So this flap prevents the formation of phrase syndrome, and also it increases the cosmetic appearance. So this is the parotid fascia. You have to look for the glistening parotid fascia, and you have to carefully dissect it. And this parotid fascia is attached to the masseter also, so it's also called parotidomasseteric fascia. It's a very dense fascia, and the S-mass flap should be above it. But anteriorly, once you cross the anterior margin of the masseteric muscle, so you need to be careful because the facial branches, they enter the S-mass flap. So while you are dissecting, you should limit the dissection to the anterior border of the masseteric muscle. And what is the first step after elevating the flap? Will be to identify a great auricular nerve. It's a good exercise to first start with identifying the greater auricular nerve. And the landmark for that is the McKinney's point. That will be around 7 or 6.5 centimeters inferior to the extraorbital canal at the midpoint of the sternocleidomastoid. So here you can see the greater auricular nerve. It divides in the posterior branch and an anterior branch. If you're doing superficial parotidectomy, of course you need to dissect and cut the anterior branch. But make sure you keep the posterior branch intact because that gives sensation to the lobule. So the patient might complain of sensation, decreased sensation if you accidentally cut the posterior branch. And the next step will be to dissect the muscles, the sternocleidomastoid and the posterior digastric. So you do a sharp dissection. In real life, you use a cautery, and of course, you need to do a traction counter traction so that the muscle and the fascia separates. So you have to separate the parotid tissues from the sternocleidomastoid, and then deep to that will be the posterior belly of the digastric. And you can differentiate between the sternocleidomastoid and the posterior belly of digastric by the direction of the fibers. So that is the posterior belly of the digastric. And it attaches to the sternocleidomastoid at the digastric ridge. As you know, that digastric ridge is one of the landmarks for the exit of the facial nerve. And the most important step in the parotid surgery is the identification of the facial nerve. So what are the landmarks you use? You always use landmarks, bony and soft tissue landmarks to identify. And there are primary landmarks and supplementary or alternate techniques. The primary landmarks are, of course, the ones that we saw now, posterior belly of digastric. It emerges superior and superficial to the muscle superior border. So you need to dissect the digastric all the way till its attachment to the sternocleidomastoid. The mastoid process, and then superior and superficial will be the trunk of the facial nerve. The other landmark is the tracheal pointer. So ideally you use at least 2 or 3 landmarks to identify the position of the facial nerve, not just one landmark. So it is ideally 1 centimeter deep and inferior to the tracheal pointer. And the other landmarks are tympanomastoid suture. This is almost the most reliable landmark. You can feel it by your hand. It's a V-shaped defect at the base between the mastoid and the tympanic bone. And stylomastoid foramen is like, if you have reached the stylomastoid foramen, you have gone too deep. And what are the other techniques? You can identify the styloid process in case of revision surgeries. And another way of finding the main trunk is retrograde dissection. It's easy to find the terminal branches of the facial nerve, and you can dissect it in reverse direction. And nowadays it's very important to use facial nerve monitoring, and that is a really good advance. And so here you can see the dissection of the tracheal pointer. The tracheal pointer is basically a conical tip at the middlemost part of the tragus. And the facial nerve will be 1 centimeter inferior and deep to it. So now the tracheal pointer is identified and the possibility of the digastric is identified. So usually the facial nerve will be in the midpoint of these 2 structures. So that's why we always take at least 2 or 3 landmarks to identify the facial nerve. So keep your instruments superficial to the posterior belly of digastric, like how we did now. And here is the main trunk of the facial nerve. You see here, this is the posterior belly of digastric, and this is the tracheal pointer, and right in between is the main trunk of the facial nerve. So what do you do when you find out trace the main trunk of the facial nerve? You need to dissect the parotid tissue away from the facial nerve, and the maneuver you use is spread, lift, and cut. You insert your mosquito, you spread, and then lift it and cut it. And in real like surgery, you need to use Popey's irrigation if you are using a diatherm. They are dissecting the sans serines, the branches. That is the cervical branch, and here you can see the final picture. So this is the temporofacial branch and the cervical facial branches, and you can see all the terminal branches of the facial. That's it. Thank you very much.
Thank you very much. Any questions? Any comments? Something to add? Thank you. Thank you very much.
I just want to add that during the cadaver dissection, the nerve might be not same like in life surgery. So you might cut it, and then it will be very difficult to find.
Mostly blue.
Yeah.
Mostly blue.
Try to slow down once you reach the point of